to congratulate all radiologists in the world on this beautiful International Day of Radiologists. I want to thank our professors that I'm really honored to stand before them today, and to thank the people of the Radiologic Society of Kurdistan for this great effort in organizing this huge event. Your efforts is very well appreciated, and I'm so happy to be here. I want to present very short introduction on the interventional neuroradiology. Due to the limit of the time, I have like 15 minutes. I'll try not to go more than that. First of all, it's a radiologic subspecialty that deals with pathologies of the brain, spine, meninges, head and neck by use of catheters through endovascular approach. Why radiologic is underlined? Because nowadays neurologists, neurosurgeons, and even cardiologists are going into the field of interventional neuroradiology, which in my opinion is a strictly radiologic procedure. So in order to have a unit that is class A in interventional neuroradiology, what do you need to have? First, you need to have interventional neuroradiologist, you need to have a neuroradiologist, a neurosurgeon, gamma knife surgeon, a neuroanesthetist, and ICU, dedicated staff and dedicated cath lab. And this is in order to have a class A unit. Unfortunately for me, I had the honor of being a fellow at the Zurich University Hospital in interventional neuroradiology for a year, and I worked in this 16 floors building dedicated for brain sciences. It has everything: neuroradiology, neurology, neurosurgery, neurophysiology, whatever neuro, it's in there, in one building. And I had the honor to work with this great man, Professor Valavanis, who is literally invented interventional neuroradiology, and even the catheter that he used to work with was named Valavanis catheter. They put the catheter just for him. Unfortunately, he passed away several years ago due to lung carcinoma. He was a heavy smoker, just like me. Anyway, so why it's so special, the interventional neuroradiology? First, because the diameter of intracranial internal carotid artery is only 4 millimeter. You are working with a vessel that's 4 millimeter. So we need to use micro catheters of 1.5 to 1.8 French, and micro guide wires that are 0.008 to 0.014 inch in diameter. That's just like a hair thickness. It has a lot of complications, and they are serious complications like stroke and intracranial hemorrhage, and most of the time it's done under GA. Almost always deal with abnormal vessels, and they are weak, very susceptible to rupture at any time. And if no complications happen, discharge the patient within 1 day. So it's amazing. What are the pathologies that do we work with? First of all, the most famous one, aneurysms, intracranial aneurysms, intracranial tumors, vascular malformations, stroke, carotid stenting, temporary and permanent vessel occlusion, and rarely inferior petrosal venous sampling. So what are the procedures that we do? First of all, it's coiling, embolization, fibrinolysis, and mechanical thrombectomy, stenting, and arterial occlusion. So what about the coiling? Coiling is done mainly for aneurysms. Coils of different sizes, shapes, and properties, hundreds of types of coils. Different techniques like plain coiling, balloon-assisted, stent-assisted, including parallel and caging, depending on the aneurysm size, shape, position, and also sometimes single, double, or triple catheter approach, depending on the situation. Also used for parent vessel occlusion and carotid cavernous fistula. So coiling, I will show you a very quick video about the coiling. Just wait. Why it's not working? It was working a minute ago. Automatic. Okay. So this is a plain coiling. It's a narrow neck aneurysm. You just put the microcatheter in it and you deploy the coil. And as the coil is deployed, the coil has a thrombogenic properties. So immediately thrombus start to form, and the aneurysm gets smaller and it gets occluded. It's just plain coiling, nothing there. This is for narrow neck aneurysm. But what about the wide neck aneurysms? Wide neck aneurysms has the risk of, is it working? Or? Yeah. Has the risk of the coil falling into the parent artery. The coil might fall into the parent artery, so we have to do something about that. So we put the guide wire. You can see the black thing is the guide wire, and you can see the and then the microcatheter, and through the microcatheter we deploy a stent, okay, to prevent the coil from falling. If it falls into the artery, it will result in stroke, in massive stroke. So you can see now the guide wire is in place, and this is the stent. Now deployed the stent, and through the stent we put the coil in the aneurysm. You can see now this is the guide wire again in the aneurysm, the microcatheter. Remove the wire, put the coil, and you are 100% safe. The coil will not fall into the artery. Discharge the coil, deploy it, and put another coil and another coil. Make it completely full. Remove the catheter. Everything is in place, and now it looks like that. Very nice, simple, and plain. Okay, this is for wide neck aneurysms. So let's see, for example, here, this is a typical case of subarachnoid hemorrhage, a tiny aneurysm seen at the basilar tip, which is one of the ugliest location to embolize, because any mistake you will end with brainstem stroke, fatal. After coil is deployed, there is nothing now in the angiography. Another application is for interventional neuroradiology is a tumor embolization. It can be used for intra or extracranial tumors like meningioma, glomus, angiofibroma, things that are very vascular. We do tumor embolization using particles pre-operatively. We occlude the blood supply in order to make the surgeon life easier. He goes, there's no bleeding, and he can work easily. Okay, most of the famous example of occlusion is meningiomas. They are very vascular, and you can see the enhancement here at the angiography. You can see the enhancement. After embolization, you can see there's no enhancement at all, indicating complete embolization. In the MRI, you can see the meningioma here markedly enhancing, and after embolization, the enhancement is much less. After a while, is much less, and in 1 or 2 days, you can see the meningioma is much smaller, and no edema, no nothing. The surgeon life is much easier. He just go take it out, and that's it. Again, another meningioma, you can see the marked enhancement, and after embolization, nothing. So it's much less vascular now. And this is the previous case on MRI. You can see the enhancement, and after embolization, there is no enhancement at all. So it will not likely to bleed. This is a case of glomus tumor. You can see the marked vascularity, and post-embolization, much less vascularity, much less bleeding. Again, a case of angiofibroma. You can see it's big, it's markedly enhanced, severely enhanced, and after embolization, there is nothing there. It's completely, it will not bleed during surgery. Another application that's common is carotid stenting for narrowing of the carotid artery, internal carotid artery plaques, and it's done using this technique. You can see very fast video. We go through the plaque, and we deploy a basket to help protect from distal embolization. This is a basket, and then using a balloon, you can see some particles dislodged distally that are captured by the basket, preventing stroke. And after that, we deploy the stent and fix the stent in place by a balloon, and now you see the balloon will come. Okay, and the balloon is fixed in place, and now we remove the whole thing and preventing distal embolization. You'll see the basket is removed and everything is okay, and the narrowing is gone. This can be done for up to 99% stenosis. 100% no, you need carotid endarterectomy. 99% you can do stenting. So this is a case. You can see the severe stenosis here at the origin of the internal carotid, and after balloon and stenting, you can see the stenosis is just this tiny thing. Regarding stroke, mechanical thrombectomy and endovascular recanalization, it's not that easy because time is brain. You need to diagnose, to go to the room, to the catheterization lab, and you need to extract it all within a few hours, which is very difficult. You have very short time to save the patient. And how it's done? It's done like that. First of all, when you have a stroke, your patient has a stroke, sorry. Okay, you go through the stroke, through the embolus, the thrombus, and you deploy a mechanical thrombectomy device. There are a lot of kinds of shapes of diameters and a lot of things. So the thrombectomy device is deployed in place, and what happened? Yeah, this is a thrombectomy device. You can see it. Leave it immediately. Blood flow will be restored. Leave it for a while so that the thrombus will sink into the device. Okay, and then when you want to remove it, occlude the parent vessel to prevent distal embolization. Suck it, and then everything is restored, blood flow is restored, and you save patient from stroke. So that's regarding mechanical thrombectomy. Regarding vascular malformations, including AVM and AVF, they have complex anatomy, need a team of interventional neuroradiologists, neurosurgeon, gamma knife surgeon. It's very risky due to very weak artery walls, and multiple sessions may be needed, and it's way much expensive. The basic idea behind that is the following. Normally, normal blood flow is seen like that. It's from artery going to capillaries, going to vein. Abnormal blood flow, or AVM, it's artery and vein, no capillary in between. So you'll have a very fast blood flow. What you need to do, or what we do normally in embolization, is we just go through the feeding vessel and deploy something that will occlude this abnormal connection. How that is done? Through endovascular approach, femoral artery puncture, going up through the aorta, through the carotid, and into the intracranial ICA, and reach the feeding vessel, deploy our embolizing material, which can be glue, can be polyvinyl alcohol particles, can be onyx, something called onyx, something like a glue, okay? And the whole thing will fill with the embolizing material, and no blood flow is remaining, and now we have restored normal blood flow, okay? And we'll see some example of that. We can use histocryl, that's the glue, or onyx, or some particles, polyvinyl alcohol or PVA particles, and it applies the same to arteriovenous fistula. This is a large AVM. You can see the abnormal connection here, and this is the histocryl deployed in place, and after embolization, everything returned to normal, no AVMs. And with that, I would thank you and leave you with this beautiful view from the city of Zurich in Switzerland. Thank you very much.